Tomorrow belongs to those who prepare for it today. A seed planted today takes root and grows into a tree that bears fruit in the future. Over 110 years ago, a seed was planted. Today, that seed, the idea of excellence, has grown into the University of Pretoria, South Africa's largest contact research-intensive university. 9 faculties and a business school are spread across 7 beautiful campuses, which are home to over 50,000 students, ready to make an impact in the world beyond university and join our global network of nearly 300,000 alumni. Future-focused, sustainably developed facilities and cutting-edge multi- and transdisciplinary research are underpinned by a desire to transform lives and have a positive impact on communities and the world. Excellence in teaching, learning, research innovation, arts and culture, and sports puts us firmly amongst the world's best universities. Knowledge is not just what is in books. It is the wisdom to apply it, to nourish and nurture the seed so that it takes root, grows tall, bears fruit, and branches out. UP plants that seed, that tiny bit of curiosity, creativity, critical thinking, hope, the desire to care, respect, help, and innovate against all odds, to grow, to leave your mark, to excel, to challenge the norm, to think, to rethink, to discover, to inquire, to lead, to have courage, to make a difference, and to persevere. This is the University of Pretoria. We make today and every day matter.
Welcome to the second day of our COVID-19 webinar, Reflections on the Scientific and Social Impact of the COVID-19 Pandemic. First of all, thank you to the Vice-Chancellor, Professor Coupe, and to Professor Agudi and the panelists for arranging this and taking part. And this morning we turn to the role of scientific evidence during the pandemic. One consequence of the COVID-19 pandemic is that the public has been exposed to a lot of science quite suddenly. They've heard about zoonotic diseases, immune responses, vaccine development, and been exposed to a lot of graphs and statistics, exponential growth and log curves, linear curves, flattening the curves. They've also realized that there's a lack of consensus among scientists and a lot of uncertainty in the data. And then we're going to be also talking about the interaction between the science and the politics. The task of medical experts like Professor Gray has been to give scientific advice and not political advice, and the ministers make the decisions. And they say, we're following the science, but very often that science is not available to the public, and there's a bit of a lack of transparency. And we're also going to be covering mathematical modeling, which has been very important in the face of all this uncertainty. It's used to evaluate the effects of different control strategies on the infection rate, the hospital burden, the death rate, and just immunity in the population at large. And of course the economic consequences. And models work with data that's changing all the time, and they have to make simplifying assumptions. So it's not surprising that they come up with very different figures, as we've certainly seen here. Now, to introduce the speakers who will discuss these issues with us. First, we will have Professor Glenda Gray, who is the first female president and CEO of the South African Medical Research Council. She studied medicine and pediatrics at Wits University and is still a professor there. And Prof. Gray's research and activism around HIV has earned her a whole string of awards. But most importantly, recently, she has been chair of the research subcommittee of the Ministerial Advisory Committee on COVID, so providing scientific evidence to the National Coronavirus Command Council. Our second speaker is Professor Robin Crew, who's Professor of Zoology and Entomology and a Senior Research Fellow at the Centre for the Advancement of Scholarship. He has held many administrative positions. He's been Dean of Science at both Wits and the University of Pretoria, Deputy Vice-Chancellor at the University of Pretoria, Director of the Centre for the Advancement of Scholarship, and President of the South African Academy of Science. His research interests are in the social behaviour and chemical ecology of social insects, especially honeybees. And our third speaker is Professor Neil Bruduna, who is an emeritus professor in physical chemistry at the University of Stuttgart, and also a visiting professor, a regular visiting professor at the University of Pretoria, where he's based in the Centre for the Advancement of Scholarship. His current research focus is on alternative chemical energy research, especially the conversion of carbon dioxide to liquid fuels using solar energy. Okay, now we can begin with our first speaker. Gray.
Sorry, are you able to see my screen?
Yes.
Okay. Good morning, and I'm sorry for the noise. I have a lot of ambient noise because they're busy renovating our offices outside. So I do apologize if sometimes there's a little bit of noise. So I'm going to talk today about the role of biomedical science in the COVID-19 pandemic. And I won't be covering any of the humanities or social sciences, as I believe a lot of that was covered yesterday. And so thank you very much for the University of Pretoria and Kaz for inviting me to take part in this symposium. So I'm just trying to, can you see the next slide? So I wanted to start off by just saying that SARS-CoV-2 is a beast of a virus, to quote a colleague of mine, Francois Fenter. This pandemic has now affected more than 200 countries, with more than 41 million cases worldwide and over 1 million deaths. In South Africa, we have over 700,000 cases. Official deaths are around 18,700. And the South African Medical Research Council has reported in this period of time over 46,000 excess deaths. Just to preface this talk is just to look at the epidemiology of COVID-19. We know that from molecular biology, we know that the genetic sequence is quite close to the bat strain of the coronavirus. There's been a suggestion of a secondary host which acquired COVID-19 from bats and transmitted it to humans at the wholesale seafood market. And the possible candidate is the pangolin, which is a mammal whose scales have been used in traditional medicine and is the most illegally trafficked animal in the world. Just to understand why this is such an important epidemic is to say that there are 4 non-SARS-like human coronaviruses. These coronaviruses usually cause mild respiratory illnesses, both naturally and with experimental challenge, and occasionally they cause lung disease in immunocompromised persons. And what we see with coronaviruses is seasonal activity. Winter, early spring, they tend to recur in 2 to 4 year cycles, would suggest that natural infection does not give long-term protection. And it's important to know this persistence. And obviously, this type of seasonal persistence is a worry for us with SARS-CoV-2, albeit this disease is quite different from other respiratory coronaviruses that we've seen. Just to let you know why coronavirus is much more severe than any of the other coronaviruses, is that this virus deeply invades tissues of the human body, the lung, the heart, and the GI tract. It lands on our nasal epithelium and our lung tissue and replicates in this tissue. And this COVID-19 is 1,000 times better at infecting humans than its closest relative found in bats, because it's evolved from several coronaviruses which have merged together. And this has found that the ACE2 receptor, in which the virus is used to enter the body, is the key, and how a person gets infected, and where a lot of the drug discovery and virus vaccine development has been focused on. Just to start off, to say that the central theme in this epidemic has been around evidence-based decision-making and the role of science. And so wherever you read at a global level, politicians and governments are always talking about evidence-based decision-making and the role of science in this epidemic. But what has been the strength of biomedical evidence in this epidemic? And I think I want to say that the strength of evidence has been variable shades of grey. And if you look at the biological sciences, I think important and robust has probably been the molecular biology and the computational biology, and looking at the pathogen-host interactions, and also developing the diagnostics. But certainly our transmission dynamics have been poorly articulated and often wrong. It was very late in the epidemic where eventually scientists and WHO accepted that this could be not only, that this could also be airborne besides droplet and other modes of transmission. So we've been wrong on the transmission dynamics. In terms of medical science, we've seen how politics has interfered with the development of interventions, and we've seen how drugs have been repurposed from other drugs. The whole issue of hydroxychloroquine and other interventions that have been posed as alternatives. Interferon procurement. We've just seen a report in the newspaper about the SANDF procuring interferon without any evidence and spending 200 million rand on drugs that may have no purpose. Vaccine development, also we've seen some controversy around vaccine development and how vaccine experiments have occurred, and the lack of, in some areas, the lack of data into the design of the phase 1, phase 2 clinical trials, and the whole interaction between the US, China, and Russia in terms of vaccine development. What's very important is obviously the immunology and our immune response and mechanism of protection. And even that we've seen has changed over time when we start to hear about reports of reinfection, and we start to hear about the role of viral load in the severity of the disease and the immune response that is important. As far as physics, chemistry, and engineering science are concerned, these are very critical for the protection of healthcare workers. And we've seen the problem with the quality of PPE, which has impacted on the safety of our healthcare workers. The emergence of ventilators, high-flow nasal oxygen respirators have all been very important for managing the COVID disease in the hospital. The importance of chemistry is obviously in the role of rational drug design and to help us with crystallography and understanding the viral structure of the virus. Mathematical and computer science, which I'm not going to deal a lot with, but has also caused a lot of controversy in trying to predict the epidemic. And we know that mathematical and epidemiological simulation is supposed to help us predict, anticipate, and control epidemics. And you can get it all wrong if you simulate the influence of certain variables and you don't have those variables accurately defined. I think one of the most controversial issues around biomedical interventions has been the issue of public health interventions, and the evaluation of non-biomedical interventions to prevent transmission, or the value of the public health interventions to curb the spread. And obviously these particularly are lockdown strategies, the role of non-pharmaceutical interventions, the risk-adjusted strategies that we have in South Africa, and the importance of test and trace, which we've seen in certain countries that have been able to control the epidemic by having a fastidious test and trace capability like we see in South Korea. So how have politics impacted on science? And we see this from the very beginning, when the doctors in China first started to see the occurrence of this viral pneumonia. We saw that there was a shutdown in information. We also saw an inability or unwillingness to provide precise information about the spread of the virus by government agencies. And in China especially, we saw the hiding and censoring of reports. We've also seen an extraordinary measures by government to show they're in control. The lockdown, the easing of the lockdown, the going back into lockdown, closing down boroughs and areas, or suggesting to close down provinces or cities. So we've seen these extraordinary measures by government to show that they definitely are in control. But we've also seen governments delivering ambiguous advice. And we've seen even in our country, the issues around social and religious gatherings, that you're not allowed to visit your family and friends, but you can go to a religious gathering. You should make sure you are in open areas and avoid congested areas and issues of ventilation, but propagating 100% taxi occupancy. So we've seen a lot of mixed messages in how to protect people at a community level. And we've also seen politicians propagate suspect treatment interventions. And Donald Trump, I think, is the prime example of politicians influencing and trying to propagate treatment interventions that are suspect. So where has science and policy lagged? And certainly science and policy has lagged in understanding transmission dynamics. It lagged in making sure that non-pharmaceutical intervention implementation was implemented in a timeless fashion. Not so in South Africa, but in other parts of the world, we still see this interface with people in crowds not wearing masks and not adhering to social or physical distancing or hand hygiene. We've also seen how the natural history of disease in children, people not taking that into account and keeping schools closed, even though we knew at a global level that children were less likely to be affected for a whole range of reasons and were less likely to be particularly younger children under 12 are less likely to be contagious. And so not understanding the transmission dynamics really impacted on our ability to keep schools open and people avoiding understanding the natural history of the disease in children. We've seen that very, very late in the epidemic did the WHO take on the idea or accept the idea that around how the virus was transmitted and the importance of congestion and ventilation in trying to mitigate the impact of the pandemic and transmission. And also the very importance of public masking. In fact, South Africa was, made an intervention for public masking long before the WHO or the CDC actually implemented a recommendation for public masking. There's always been in the debate at a global level and at a country level is the balance between the public health impact and the socioeconomic effects of the public health impact, and trying to understand whether the treatment is worse than the disease, or whether the disease is worse than the treatment, and the balance between preventing loss of livelihoods and preventing loss of lives. And so this is where I feel policy masqueraded as science, and this was in the lockdown strategies. So to get countries go into lockdown to get transmission under control, and that is the whole reason why people go into lockdown. To get transmission under control, countries have two choices. They can either try and mitigate the epidemic by trying to slow down the epidemic to reduce the peak health demand And you can achieve mitigation by isolating cases, quarantining close contacts, and implementing social or physical distancing, wearing masks, hand hygiene, and protecting that part of the population who will have the worst outcome from being infected. So that is what we have, and this is what we heard about flattening the curve, and this is a mitigation strategy. For suppression or lockdown, a country can go for broke, and when you go for broke, your sole aim is to suppress the epidemic and stop transmission. And this suppression or lockdown aims to reverse the epidemic growth and reduce case numbers to low levels by social distancing the entire population indefinitely. And this is quite possible in certain islands, and we've seen this in New Zealand, this attempt to go for lockdown. But even in New Zealand, they don't know how long they can contain this intervention. Eventually, it has a huge impact on your ability to manage the country. So lockdown, unless you're an incredibly rich country, is unlikely to be sustainable in the long term. So in terms of the lockdown in South Africa, what have been the pros and the cons? The pros of the lockdown is the flattening of the curve, bringing time to learn to manage the disease, and bringing time to improve health system response, improve hospital bed availability, and to try and increase testing in our country. The alcohol ban and the curfew decreased the unnatural deaths and trauma-related hospital admissions, and the wearing of masks in mandatory certainly helped slow down the transmission. We had very good initial implementation of NPI, and initially we had a good social cohesion and public buy-in of the lockdown. But there have been devastating cons, and that is the economic devastation, the corruption we've seen, the 40% loss of school year, the suspension of school feeding schemes, which have exacerbated childhood hunger, and the issues of mental health and gender-based violence, as well as impacting on the delivery of other healthcare like HIV, TB, antenatal care, and the immunization of children. And so when we look at this balancing act and look at the preventing of lives and livelihoods and what a lockdown does on the collateral morbidity and mortality. And so in South Africa, we have seen excess deaths from about mid-May. And we've seen around 46,000 excess deaths, although the official report is around 18,000 deaths in our country. And obviously the excess death could be attributable to COVID that was not properly diagnosed on your death certificate, or it could be because people had other illnesses that they could not access the hospital care for. And it's very important to know that overall there has been excess deaths in this period, and it's probably an interplay between both COVID and other non-COVID issues. When you look at the socioeconomic impacts of a lockdown and what happened in terms of livelihood, you can see that in South Africa, 3 million jobs were lost. Most women, 2 million women lost their jobs. The significant amount of newly unemployed came from households without social grants, and that 1 in 3 people who earned an income in February did not earn an income in April. And the poorest of the poor were the most people that were affected by this lockdown in South Africa. We see also people running out of money to buy food, people going hungry in the household, and children, about 1 in 5 children going hungry in the last days, particularly in grant-receiving households. So in conclusion, I wanted to say that this is a new epidemic, and evidence is emerging all the time. And because evidence is emerging all the time, it's critical that we recalibrate our approaches, and it should be based on emerging information and our need to be nimble at all times. Thank you very much. I'm going to stop sharing my screen.
Thank you, Professor Gray. That was a very interesting presentation. We're going to have a discussion at the end of the presentation, so we're going to move on now to Professor Crew.
Thank you very much, Nicholson. And thank you, Professor Goody and Professor Coupe, for arranging and inviting us to join this particular webinar. I think the discussions that have taken place so far have been illuminating, and the Professor Gray's talk precedes mine has essentially laid out what the problems are in relation to dealing with this particular pandemic in South Africa. And so I would like to use this opportunity to talk a number of things that relate to science. And the presentation that I'm give are entitled Evidence, Narratives, and the Failure to Adhere to the Hippocratic Oath. And I'll explore the issues behind these in a little bit of detail in this presentation. It's interesting to me that Professor Goody used these by telling us a story. And essentially what we have had is a set of being told to us about the COVID-19 pandemic. And the question is how to evaluate these stories. So as the COVID-19 pandemic unfolds and we reflect on the last few months, it's hard to understand, even make sense of the decisions that have been taken to save lives. Now, while no one doubts that saving lives is an important role for everyone in society, the question is how to establish a sense of confidence in the population that the measures introduced will achieve this end without unacceptable collateral damage of currently unquiet dimension. Now, some of that collateral damage was explored in the presentation a few moments ago. It still remains relatively unquantified what size of that damage is going to be ultimately. Now, in a recent article by Professor Dirkser in The Conversation, he highlighted the president's claim that decision making was informed by scientific evidence. And in considering what is meant by evidence-informed policy making, I was reminded, as Professor Sharp indicated, a popular children's storybook. It's called Just Stories for Little Children, and it was published in 1902. Now, each of the stories describes in whimsical detail how various features of animals come into existence, whether they have spots or stripes or whatever. And the story I want to focus on is the story of the elephant's trunk. And it describes how the elephant got its trunk. It describes an inquisitive elephant's encounter with a crocodile that pulls its nose into a long trunk. And of course, since that time, all elephants have been equipped with a long trunk. Now, the story, while it's fanciful, does illustrate the key features of just stories that are constructed from a single piece of evidence, the elephant trunk, and then explained using a causal explanation that is a fanciful product, the pulling crocodile. These two elements, evidence and a narrative that interprets and explains the evidence, is what is used to establish policy. An additional point relates to the question of what constitutes evidence. And in this context, I'm reminded of the hint of Goldacre in his Bad Science. And Goldacre said, the plural of anecdote is not data. The point that he was making was the data that need to inform decisions need to be collected systematically and as circumspectly. Furthermore, anecdotes recount under oath are regarded as evidence by courts of law, but scientists are skeptical of this evidence and prefer to evaluate evidence that is generated via well-established experimental methods. These distinctions are not often considered by politicians and journalists, unaware of fools that relate to what is regarded as credible evidence, what are anecdotes, and how explanatory narratives are used to justify policy. So with that brief background, that brings into the current pandemic and responses to it that need to be viewed in the context of just so stories that use a combination of evidence and narrative to make a compelling story that underpins policies. Now, skeptical scientists in these circumstances activate their detector for the existence of just stories masquerading as policy. That masquerade policy making informed by scientific evidence. And I see that Gray and I are using very similar terms to describe processes like. So with mind, let's explore what may be interventions at minimizing the effects of COVID in South Africa, and the interventions that are worth exploring. First of all, banning the sale of cigarettes. Secondly, banning the alcohol. And thirdly, the introduction of fever screening. Now, the argument for banning the sales of cigarettes that since COVID-19 is a respiratory disease, and since to ever get negative on the health of smokers, particularly in the lungs, banning the sale of cigarettes will reduce the severity of the disease and make smokers to drop. This is a connection as a experience on health. So the question is, this is most so the story. Now, the WHO scientific brief for the 26th of May, there's currently no evidence to either or an interaction between the virus, COVID-19 and smoking. Both affect the health of individuals, but on timescales that are simply not comparable. In essence, smoking can be regarded as a potential comorbidity factor, but the banning of the sale of cigarettes with absolutely no influence on the way the pandemic plays out, but may have highly deleterious effects on the short-term health of individuals precluded from smoking. Furthermore, created an unnecessary loss of tax revenue at precisely when collecting this revenue to fund COVID-19 intervention was necessary, and even mentioned the effect of criminalizing an activity like this. So, the conclusion is that the moral crusade, masquerading as a health intervention, an attempt to mold scientific evidence to a preferred policy outcome, and should never have been. A precisely similar argument can be made for the ban on the sale of alcohol. I have that this is a story similar to that about the ban on the sale of cigarettes. Individuals who argued in favor of the ban cited anecdotal evidence in court based on the ICU bed, but not on any long studies that should have been the basis for policy intervention. The introduction of this ban should have been based on longitudinal studies of the impact of alcohol consumption on the use of facilities and counterbalanced by the negative impacts on the economy and the criminalization of activities that are perfectly legitimate in an open society. Again, it was a moral crusade masquerading intervention. And these two examples demonstrate that policy based on those stories undermines the public confidence in answers to the pandemic, which are related to NPI interventions that Professor Gay mentioned. And these NPI interventions can indeed limit the spread of the virus. Hand washing, masks, limiting movement, interactions between people. Finally, in a document article in The Conversation, Fuller and Mitchell explored both the physiology of fever and the utility of using fever screening to identify individuals who may be infected. Their scientific evidence shows that skin temp is not a good proxy for determining core body temperature, which is related to. They indicate that the history of the use of fever, particularly as it was introduced for the first SARS epidemic, points to it being ineffective in identifying people who should be tested and vaccinated. Significant resources are being invested in equipment and human resources with very little in the way of demand sensible outcome. What is particularly about this example is that the people of South Africa are being misled by police into doing something that has little value in the misguided apprehension that it will those who are infected be identified. All of these three examples represent policymakers in the context of dealing with the pandemic and show a lack of commitment on the part of making to critically examine the impact of interventions that introduce gratuitous limits on freedom.
Hello, we are having trouble with hearing Professor Crew properly, and the people running the technological side can perhaps work a little bit to improve his connection. And meanwhile, I think we should go over to our third speaker, Professor Raduna. The camera on his laptop is not working, so we won't have a live version of Professor Raduna, but we will have his PowerPoint slides and his voice.
Yes, good morning, everybody. I would like to thank Professor Ogude and Professor Kuppe for the invitation to contribute to this interdisciplinary event about a global and life-threatening pandemic. The keyword that I picked up from the invitation is the word modeling, because that triggered something in what I can understand, because I'm not a specialist on COVID-19. Let me start with a quote. As a student, 1974-75, I spent 1 year in northern New York, and I took a course in chemical kinetics. This course was given by a gentleman who at that time was about the age that I am now today. That was Paul Hartek. He was a famous man because he had discovered the difference between ortho and parahydrogen. So he was a typical physical chemist. But during the Second World War, he was invited by Heisenberg to a small group of scientists to work as a member of the German uranium project, to work on nuclear bombs. So what has a physical chemist to do with nuclear bombs? Well, I remember quite well that Hartek explained us why this was. He said that studying nuclear reactions is just the same as chemical reaction kinetics. The difference is that what is called rate constant in chemical kinetics is called reaction cross-section in nuclear reactions. Why am I telling you this? This is something that we find quite often, that we learn something in one field and then we discover that in a quite different field we can use the same way of thinking, and we expect from academics that they can transfer the knowledge from one field to another. And in this sense, I can tell you today that modeling infection rates of COVID-19 is also the same thing as chemical reaction kinetics. It's really no difference, mathematically at least, the same way of thinking. So, what is this infection process that we have with COVID-19? We call it an autocatalytic reaction. And we say that we have these susceptible people who can be infected. We designate them with S, and then we have the people who are infected with COVID, and we call them C. So if S meets Z, then you end up, if you have an infection, you end up with 2C. This is an autocatalytic reaction. If you have a normal catalytic reaction, you would have, for example, S plus a catalytic C going to some new molecule B plus the same catalyst back. But here we are getting two catalyst molecules from one. Therefore, you're getting more and more, and that enhances the reaction more and more. You can describe it with a mathematical equation, a differential equation that you find on the upper right. So the change in concentration with time of the infected people is proportional to three terms. One is the C, the concentration or the number of corona-infected people. The second one is a concentration of susceptible people. And the third one is a proportionality constant. We call it a rate coefficient. So this is a differential equation, an easy one that you can solve, and it leads to an exponential increase of the concentration of the number of infected people. So in the image that I've drawn here, you have a number of suspected people in a certain box and a number of susceptible people, and you have an infected person, and the infection goes by close contact, not necessarily body contact because it's an airborne virus, so mostly it comes, as you have heard already this morning, it comes through the respiratory system, but you have to come relatively close to be infected. But you have the proportionality of the concentration of S. So in a big crowd, in a dense crowd, you have a much higher chance to get an increase of the number of infected people. That can be outdoor or it can be indoor in some clubs. That's where most of these infections happen at first. Now, so we have this proportionality to the three parameters. How can we reduce the infection process? Well, you all know social distancing, wearing masks, hand washing, and staying home. So what means social distancing? In the terminology of chemical reaction kinetics, you would say you pack your molecule S with something, with a spacer that takes care of a distance so that the reaction doesn't come so easily. This is social distancing. So we say maybe 1.5 meters, 2 meters, and then the probability that the infection happens becomes much lower. Outdoor, the infection rate is lower if the distance is obeyed because there is always some wind, and that blows the concentration of the virus, blows the virus away and decreases the concentration of the virus. Whereas indoor, you contain the virus and it can build up in concentration. Now, if you still obey the distance, that may be okay, but if you have an air conditioner that doesn't filter out the virus, if it just mixes the air, then the distancing doesn't help indoor at all. So wearing masks. There have been lots of discussions of masks. Recently, I've seen an assessment of the efficiency of masks. It said the efficiency is about 30%. Well, you may think that 30% is not much, but I will explain you afterwards that it can still help. Masks prevent the infection of others if you are infected, because it can catch the droplets on sneezing and coughing. There's maybe different types of masks which can prevent your own infection. For that, you need very tight masks because you will probably not breathe in the entire droplets, but the liquid has boiled off already and the virus is very small and it can pass through most of the fabrics that the masks have. So you can have very tight masks with a valve, maybe with some agent that can take out the virus. And then there is, of course, there's homemade masks. Now, what are they made from? Well, all possible things. So homemade masks, some of them may be fine, some of them may be worth almost nothing. So the 30% that I'm quoting there is some average overall of the masks that are being used. And then the effect of hand washing. Everybody swears on the sanitizer alcohols. Actually, soap, just normal soap or grandmother's hard soap is really more effective against COVID than alcohol. But if you use alcohol, it should be about 60%, and then it's also effective. Whereas alcohol is quite more effective, probably for bacteria. Here we have the active cases in South Africa as a function of time between February and a few days ago. And you see that we have an increase. I'm giving you the equation again with the 3 parameters. And I said that this equation leads to an exponential increase. That is the same exponential that you get in nuclear bombs. Nuclear bombs go to a point where you get an explosion. But in reality, the exponential in reality goes to infinity. But in nature, nothing goes to infinity. At some point, there are certain things which cause the curve to bend over. So in March, around 20th of March, we had the first lockdown in South Africa. That was about the day or 2 days after I left South Africa on one of the last planes that left it. And we don't quite see whether that first lockdown had an effect, because the number of infected cases was very low at that time, and it actually increased exponentially. You see the exponential on it, and you see the exponential matches the measured curve quite accurately up to about beginning of July, and this is roughly where the second lockdown set in. Well, we have this bending over of the curve. Of course, at some point, people who are infected, they recover. If they are lucky, after 2 or 3 weeks, they are no longer effective, so we have an additional term with a negative sign. And some of them are not so lucky, they die, and they are no longer infective either. So if this comes in, then the curve bends over. Some people say, well, we can just let it go. At some point, people will be immune. We have herd immunity. Herd immunity would reduce the number of susceptible people, and it would reduce it enough to bring down the infection rate. Well, that happens at much higher concentrations. We don't really want to go to that high concentrations because herd immunity would happen at a great cost, economic cost, and health cost. So, how can we reduce the infection rate? We have these 3 parameters. So, we can reduce the concentration of S. So, we do social distancing, we avoid going into crowds. Of course, if we have few infected people, the rate will also go down. If we live in a rural area where the number of people is low, then the rate of infection is also likely to be lower, but we can also try to decrease the rate coefficient. And this is what we normally do. So there, one has set up models. I've given you only the first and explained only the first part of the model because that is easily to understand. But full simulation models are more complicated. You start on the top with a number of susceptible people, then they may be exposed, but they may not be infectious. At first, they have no symptoms, but then some of them become infectious. They are the ones at the right-hand side, and some of them are exposed, but don't show any symptoms, but are also infectious. That's the one at the left-hand side. And then they may go over to the infectious and symptomatic stage after maybe 3 days after infection. And then, if they are lucky, then they recover. So you see here, you have several more concentrations. These are the blue boxes, and you have a rate coefficient for each of the blue arrows, and there may be some further arrows that are also shown here. This is one of the models. This is actually a relatively simple model. You can also have more complicated models. I don't want to explain you this. One can solve these differential equations, and the question is then, what do we learn? Simulation models are complex and require many parameters. The parameters may change frequently when the government comes up with new decisions. We can calibrate experimental data, like for the exponential increase. And that, for the exponential increase, that provides two parameters. If we have a bend over of the curve, maybe we can get a third or a fourth parameter that we can calibrate. But the rest is guesswork. Guesswork, but also we may be able to do some experiment if we do a lot of measurements, and we can get a better guess of some of the parameters. But we should not forget, the real picture is always very inhomogeneous. We have areas, cities with high populations, we have the rural area with low population densities, we have different age groups, which matters, we have care homes, we have youth clubs, we have festivities. So the predictive value of the simulations is rather low, I would say. You can say maybe disappointingly low. Well, I'm not quite sure. They are still useful because you can play around with your models and change one of the parameters and see what the influence is when you change one parameter or when you change another parameter. And this gives you an idea of how the whole multiplication of the cases works. Here we have some graphs which show the total active cases as a number of time, as a function of time, for different complying with physical distances. You have the top curve, the brown curve, which says that it is for 70% of people complying with physical distancing guidelines. And the physical distancing started at the broken line after 50 days. And you see the curve doesn't change immediately, but after 10 days or 2 weeks, it changes to bend over, but it still goes up. And I've given you a parameter r greater equals 1 for that curve. Now this parameter r is an important parameter. It's a reproduction factor. A reproduction factor of 1 means that one infected person during the time where it is infective infects in the average one other person. So in that case, the number of infected persons would remain constant. If r is greater than 1, we would still have an increase. If we can get r below 1, we will get a decrease. So for 80% compliance with social distancing, we would get the green curve, and for 90% compliance, we would get the blue curve. Yes, now, if you think the brown curve has maybe an R value of 1.2, and then you start wearing masks with an effect of 30%, then the R value would go down from 1.2 to maybe 0.85. So it would come below 1. And the overall effect would be that if everybody complied with social distancing or with wearing masks, that we get a decrease, actually. So even for yourself, 30% may not be satisfactory. You might think it's not worth wearing the mask. Overall, it's still worthwhile to do it. If you then stop complying with these measures, then the cases will go back up. Now, there's different things that you can simulate. The black curve here, the upper curve, is if you do nothing. It goes up to the top until you get herd immunity. And what is plotted here is the critical care beds that are occupied per 100,000 people of population. So you see it goes up to almost 300. You need about 300 care beds if you want to go to, if you want to do nothing and just wait for herd immunity. If you then close schools and universities, you may come to the green curve. If you do case isolation, you come to the brown curve. If you do case isolation and household quarantine, you come further down. And if you combine many of the measures, then you come to the blue line. This is just a schematic, I believe. So for herd immunity, you need, as I learned, about 50 to 70% of infected people, or people who have been infected. Because then the pandemic breaks down. You can do that also by vaccination. Once you have a vaccination, we don't have a vaccine yet. This just means that there's too few susceptibles remaining. So the hospital bed capacity would be far too low to treat herd immunity, and we need a combination of different measures to bring these curves down enough so that we can, that the hospitals don't run out of capacity. Now here is statistics for Switzerland, also for February. Then you see that mid-March it started to increase quite steeply. Then we had lockdown, and you see that it was quite successful. The numbers came down quite a lot, and then the lockdown was released early June in steps, released more and more, and now all of a sudden, beginning of October, you see that the number of active cases are shooting up again quite steeply, quite frightening. It's shooting up more than what we had in March, and at present we have a daily increase, that if we compare that with the United States, Switzerland is, at this point, is worse than the United States. So we need additional measures, and of course we have now the discussions how far the lockdown should go to get the situation under control. And the lower curve gives you the number of daily deaths. And you see that in April, the curve looks quite the same as the curve of active cases. And then it comes down to very low numbers. And you see that in August, it doesn't come back up much. It starts coming back up now. Of course, the death rate will always be delayed by 2-3 weeks after the increase of active cases. So we are afraid that we will see more of an increase, but it's quite a bit lower than what it was in April. Why is this so? Well, one reason is that today people who are infected are much younger people than what they were in April. In April, we had a lot of people above 60 who got infected, and they are much more at risk when they are infected. And there is a second thing. I think our hospitals learned very early on already how they can treat the people when they come to a hospital. And there were investigations by investigating dead bodies and looking at what has happened, and they found that a lot of these people had blood clots in the legs and in the lungs and in the brain, some of them, and in the heart, and they died by heart failure or brain failure or kidney failure or also lung failure. Also in the lungs, you find these blood clots. So one realized quite early on in different countries, in Hamburg, in Germany, in Italy, in Switzerland, and also in South Africa, I know that one was aware end of March that actually COVID is only partly a respiratory disease, but it's to a large extent, it's a disease of inflammation of blood vessels and of getting blood clots because of these infected, inflamed blood vessels. And therefore, patients who come to hospital are often getting at first some medication against inflammation of blood vessels and for blood thinning. And that treats, of course, the symptoms, not the virus, but it helps a lot that people survive and get back out. Now, for Germany, the curves look quite similar. I don't need to tell you the same story again, but here is the same statistics for the United States. You see, in the United States, it comes a bit later, and the curve just goes up in steps and steeps rising. And furthermore, the number of daily deaths, it does go down, still goes down a bit, but not as much as it went down in Europe. The question is, why is this so? Well, this is a difficult question, but I suspect from an interview that I heard about 3-4 weeks ago of a United States medical professor who told in that interview that they are just learning that it's not only a respiratory disease, but the blood vessels are affected a lot. And it seems to me that maybe the US doctors didn't read the international literature because that was already known in early April, published in early April in Lancet and so on, that one has to look out for inflammation of blood vessels and for blood clotting. So the reason for lower death rates, the age of population. The average age in Europe is 43 years, and the fraction of people above 60 is 25%. In Africa, the average age is only 20, and the fraction of people above 60 is almost 5%. The age distribution of people in intensive care because of COVID in Switzerland is given in this plot. And you'll see that the maximum is for people the age of 60 to 70. We call that the risk group, above 60. But nowadays, the number of people who are getting hospitalized or getting infected is much higher for people at the age below 50 or even below 40. And in Africa, where people don't get so old, the younger people, they may get infected, but they may survive their infection. And they might not even all notice that they have been infected. So improved medical treatment of symptoms, not of the virus, reduces the risk. Also, hopefully at some point of the virus, of course, the risk of failure of the various organs. The anti-inflammatory agents, I already explained you this. So let me finish my talk with this picture. I don't know whether you know the story of Bremen's town musicians. You have the donkey, an old donkey who realized that he will soon get slaughtered, and he managed to escape. He ran away, and he met an old dog who also was close to the end of his life, and the tomcat who was also quite old, and even a male rooster, yes, who had the same problem. So they got together, they said, let's go together through life. And they found an old house and said, well, why don't we live in that house? But the house was occupied by a number of robbers. So they built this pyramid of threats. They made a big noise and they chased the robbers away. So this is the pyramid of life threats. Today, we have a similar pyramid of life threats. It starts, say, with global warming, with the ice melting in the Arctic and in the Antarctica, and the wildfires in California, in Australia, in Brazil, and even in Siberia. We have social unrest at various places in the world, not only the Black Lives Matter movement. And on top of all this, we have the COVID pandemic. This is today's pyramid of life threats that we have to cope with. So I thank you for your attention. I wish you safe landing from this threat, and please use a mask. Thank you.
Thank you, Professor Ruud. That was a memorable second last slide and a very interesting talk. Before we go to the question and answers section, we need to go back to Professor Crew, probably without video, so that he can finish his talk.
Thanks very much, Sue. I've finished dealing with the three examples that I wanted to mention, but I wanted to explore just another two Just So stories from the recent past during the crisis of another pandemic. And the first of these relates to the supposed treatment of AIDS, which was called Virodine. And in this case, a toxic laboratory fixative was touted as a potential treatment for AIDS. The scientific explanation for its potential efficacy was, of course, similar to that proposed for bleach by President Trump. But what we fail to recall about the Virodine saga is it received substantial local funding for clinical trials and patent protection, and was supported by the Minister of Health of the time. Simultaneously, another Just So story was in circulation, propagated by the Department of Health, which would not support the provision of antiretrovirals to pregnant women to prevent mother-to-child transmission of HIV, on the grounds that these treatments were toxic. So a known toxin with no therapeutic effect was promoted in preference to antiretroviral treatments with known therapeutic value. And I think this points to a lack of any kind of sober evidence-informed basis for policy making. And naturally, this, of course, was reversed in 2003, I should say, largely as a result of Professor Gray. So I think this raises some questions for South Africans. And that question is why responses to crises of public health have resulted in policy interventions which were not based on any credible scientific evidence. And given the two episodes I've described, one in relation to HIV and the second in relation to the SARS virus, we should be certainly circumspect about allowing the current Minister of Health to amend the Health Act to give him greater powers of intervention. Because given the track record of ministers of health and given their lack of respect for freedoms conferred by our Constitution, it would be a retrogressive step, I think, to allow them to have these powers. So now I would like to finish with a final point. And that is that I would like to make this in relation to the medical profession in general and the apparent lack of concern for the Hippocratic Oath that all of them took in some form or another when they graduated. Now, the interesting thing is that amnesia about the Hippocratic Oath is certainly not a new phenomenon, as has been demonstrated in extreme examples, such as the medical experiments in Nazi concentration camps or the treatment of prisoners of war. And so the question is, why do I raise this in relation to the current pandemic? And I do so because there are elements of human rights abuses which are taking place in hospitals as part of the NPI responses to COVID-19. And these human rights abuses are occurring without apparent reflection or protests by medical practitioners. Let me just say, why do we accept that elderly people should be isolated and neglected? The answer is, of course, that they may be at greater risk of infection and ill health, but they have one life. And that one life may or may not be able to be saved. And surely the quality of that life is what is most crucial. And I would like to ask, is it really acceptable to say that families need to greet them through glass screens and people in their 80s and 90s should not be allowed to touch and hold members of their families who are not at risk from their elderly relatives and actually pose a relatively small risk to those relatives? And secondly, how have we comprehended the reports of death from loneliness, madness from isolation, and deep depression from being denied access to those we love most? The deaths in care homes are deeply troubling. But these infections largely came from care workers who moved from one care home to another rather than from family visits. And similarly, individuals who had been admitted to hospitals for treatment of conditions other than COVID-19 were either denied access to their relatives or given ludicrously short periods of access. And my question is, how did we come to this madness? How did we allow our society and civilization to permit this to happen? This is not a discussion about balancing the rights of individuals versus the public good. It is about the abuse of rights and the removal of agency from individuals who should be given the opportunity to evaluate their own risks. I believe that permitting such interventions with apparent approval will be a lasting stain on the medical profession, which should have been much more compassionate in the way in which students are at least patients are treated, particularly as it has become clear, or clearer, I should say, who is at risk and who is not. This insensitivity to the needs of patients appears to stem from the narrative that we are fighting a war against a virus in the quest to save lives. And consequently, we have to accept the collateral damage to the elderly and to hospital patients. Indeed, in war, the narrative of dissent, which is based on scientific evidence, is threatened with punitive action and a return to higher levels of lockdown. Now, this is a false characterization, I believe. The intervention should be to limit the spread of the virus, not to wage a war, and at the same time to treat vulnerable people with the compassion that it is their right to expect. What we need is a growing awareness of the twin dangers of just so stories and war analogies, and hopefully return to truly evidence-informed policy making rather than searching for policy-informed evidence as the examples that I've presented demonstrate. Thank you.
Thank you, Professor Crew, that we could hear you much better that time. And now we want to move to the question and answer session, but I've just got a question for the technical people. At the moment, I can only see part of one question that has come up. I think that I will continue with another question that I have for Professor Gray. I've seen recently a graph showing the cumulative case curve for South Africa, and superimposed on at the time when the various levels of lockdown were imposed, and it's not, there's no apparent change in the slope of the curve with each change in lockdown level. Does this mean that the lockdowns didn't achieve anything in terms of the caseload, disregarding the effect on the medical side of things, but just the caseload in general?
We cannot hear you.
Thing, because I am not, they need to unmute me. Can you hear me now?
Yeah.
Thanks. Okay, so you can hear me. Thanks. Okay, so in terms of South Africa, it's an important question. So we were always underpenetrated as far as testing was concerned. So South Africa never ever got to the kind of testing capability that could give us a true estimation of what the cases were in South Africa. And so we should not look at our cases and think that is what the epidemic was. It was probably far worse, because we never ever tested at the kind of amounts that we needed to test. We should be testing around between 35 and 45,000 cases a day, and we only reached that in July, and then it's gone down quite dramatically. So I think that's the first thing, is that we under-penetrated with testing, so we should not use the cases as an indication of how we're doing or not doing. If you look at the reproductive rate, so the NICD has looked at the reproductive rate from the time of the lockdown to the current epidemic at the moment. And like the previous speakers have said, is the reproductive rate started to go down already in as we emerged out of level 4 and 5 lockdown. So during level 5 and 4 lockdown, it was between 2.5 and 1.5. And as we opened up the lockdown, we started to get to a reproductive rate of 1. And in August, we were just under 1. And what does that mean? It means that as the previous speakers said, is that the cases started to come down once there's a certain level of the population that have been exposed and are seropositive antibodies to SARS-CoV-2. And so during lockdown, because we weren't able to test at scale, and we weren't able to contact the cases, track their contacts and put them into isolation, we were never ever on top of community transmission. And so community transmission continued under lockdown, because people were in households, and even though they weren't moving, they were still in their communities. And so the lockdown did not control community transmission. The lockdown bought us time to get our health system in check, and bought us time to increase our testing strategy, which we needed to get up and running. And so it may have flattened the curve and slowed down transmission, but it was never ever enough to impact on the reproductive rate that is critical for controlling an epidemic. And we only managed to control the reproductive rate or get it under and around 1 was when there was enough exposure at a community level to help prevent the onward propagation of transmission. But we don't know how much immunity we have to have in a community to control this this epidemic. And so even though we think we might have good levels of pre-existing immunity now in South Africa, up to 40% in the Western Cape in pregnant women, it may still not be enough. And we will still probably need vaccinations, and we will still probably continue to be in this endemic phase of the coronavirus epidemic and have continued to seed transmissions, and particularly in areas that had less prevalence, less exposure in the first wave. And so what you saw in Europe is that most populations in Europe had only around 10% seroprevalence after the first wave, which means that 90% of people were still susceptible to getting coronavirus in the second wave. The only country that had quite high seroprevalence was Austria, that had about 42% seroprevalence, and so which mimics more like South Africa. So we can't extrapolate what happened in Europe to what happens in South Africa. And largely what controls the second wave is how many people get exposed in the first wave. And as we learn more about this epidemic, we also don't know how long immunity lasts for, and what are the predictors of reinfection. So in summary, I know I've given you quite a lot of information. In summary, the lockdown did not control or eradicate community transmission. And the only thing that will control or eradicate community transmission is a high amounts of pre-existing immunity, fastidious application of non-pharmaceutical interventions, and a vaccine. And wherever people are susceptible, we will see transmission, and we probably will see in the second wave in South Africa, or the resurgence, we'll see that the resurgence will be focused in areas that weren't exposed as much as in the first wave of the epidemic.
Thank you. That was a very interesting answer, and a lot of information. I'd like to go to a question from Professor Peter Vale, and perhaps we could direct this one to Robin Crew. He has said, could one of the outcomes of this symposium be that the Academy of Science of South Africa and the Medical Research Council could assemble a multidisciplinary group to research why we in South Africa failed to anticipate COVID-19, what we could do to avoid this in the future, and to set out a plausible playbook on what we should do next time, which will need constant updating. Robin Crew.
Thanks, Sue. I think that what Peter is proposing is an excellent idea, and I think it would be very valuable for the Academy of Science and the MRC to put a group together to look into this. My own feeling about this is that a study of this kind probably needs to be initiated in the new year, when information about this current pandemic is when in situations in which there's more evidence that can be used to determine what the course of the pandemic was and what the appropriate interventions may be for some future epidemics. And I have in fact already written to the ASAF executive officer making suggestions along those lines. So I think if one of the outcomes of this webinar was to encourage the Academy of Science and the Medical Research Council to put such a group together to undertake a study of what happened. It would be extremely useful. Thank you.
Thank you, Robin. So you're thinking about this already. That's good. We have a question from Professor Ogudi.
Thank you, Chair. Thank you, panelists, for what I think has been excellent presentations. The question is really not from me, it's to sent to us. And I think in part it has been dealt with by Prof. Rodner. And it relates to the fact that, death rates in Africa or infection rates in Africa as a result of COVID-19 have been far less than elsewhere in the world. And there is no doubt that there are multiple factors behind this. So can modeling be used to differentiate them? I know that Prof. Rodner touched on the issue of the average age population, in Africa. But there have been a lot of myths too, which have been peddled around to account for the low death rates, whether it is relating to certain preconditions, certain forms of vaccinations that Africans have had before. So can I get a response, I think, from both Prof. Rodner and Prof. Glenda Gray? Yeah.
Yes, certainly the age that you also mentioned plays a major role, but there may be many other effects. Maybe sometimes, these statistics are not always so reliable or not always so comparable between different countries. So I'm not quite sure whether the death rate, if you go into rural areas, whether you get the full death rate that happens, whether it's known that the death is always due to COVID. And then it may also be, I think that has been touched upon already yesterday or by Professor Gray, that there is some sort of cross immunity that may help to suppress the infections to some extent. But I'm really not a specialist. I think Professor Gray will probably be able to give a much better answer here.
Are you able? I'm not sure if you can hear me. So anyway, I think that there are a lot of factors that affect mortality in COVID-19, and certainly the youth bulge in Africa gives South Africa and Africa an advantage around mortality. Pre-existing immunity to coronaviruses also may cause cross protection, and I think that there's also some host genetic factors making people in Asia maybe more susceptible. There have been some data. If you look at the data coming out of the United Kingdom, certainly there has been some disproportion of Black minorities in that area, particularly Asians and Hispanics, that affected their outcome. But I think we have to be very cautious because we're seeing excess death rates in South Africa. So although the official death rates from COVID-19 are around 18,000, when we look at our excess death rates, which we collect which we've been collecting at the Medical Research Council since 30 years, we've seen that there is an increase in death rates in this period of time. Now, either some of it is due to COVID, and some of it is due to other people dying because they can't access hospital. But if you look at, if we take the excess death rates and we say, well, maybe 2/3 are attributed to COVID, that gives us our mortality rate very similar to high-income countries. And so I think that death rates are underreported. And if you don't have a sophisticated real-time death rate reporting system, our understanding of the burden of mortality in this epidemic is going to take us years to understand. Luckily, in South Africa, we have we are able to collect death rates, and we're able to discern unnatural from natural, and we've been tracking death for years, and so we know that the death rate is higher this year than it was last year, and that something happened, and an epidemic happened. And one can argue, oh well, that excess death rate, those are all TB and HIV, but we do know that there is excess deaths. And if we attribute 3/4 of them to COVID, we are actually looking at the same kind of mortality rate as we've seen in high-income countries. And now we could argue, well, why is that? And it may be because we have HIV and TB as well. We also, if you have a look at our mortality rates, we have our 50 to 60-year-olds are dying much more frequently than in any other country, and that might be because of TB and HIV. So we have a high burden of mortality in our over 50-year-olds, which is a bit different to the US, which is over 60. So I do think that the jury is not out about whether, and South Africa might be different to the rest of Africa because we have a large conglomeration of other groups, population groups in South Africa that may be also driving the epidemic, and we also might have more HIV and TB, and we also might have higher rates of non-communicable diseases. But I would be very cautious in saying that South Africa has been lucky in terms of mortality until we've really discerned what people are dying from in our country, and really have been able to really audit each cause of death in South Africa, and then we can truly say whether we were affected or not. But there will be things like the youth bulge and pre-existing immunity to coronavirus and other host genetic factors that may mitigate some of the impact that we see in South Africa.
Yeah, another question that came through, and this relates to independent groups. They say that the Independent Search Committee in the UK was set up in parallel to the government version in order to provide transparent advice and to engage with the public. Can you comment on the value of this independent group and whether there's a risk of confusion when the public when the public expects consensus around some of these issues?
Was this for me?
I suppose all of you can respond to this, all the panelists. We should.
Okay. Well, I'll start. I mean, I think that I think that there's a difficulty in all epidemics between scientists, policymakers, governments, and politicians, and there's always going to be some friction between all of us because we all see things in a different way. I do believe that there's importance for both independent scientific opinions and the government use of scientists to try and help them optimize their response. But I do believe that we have to be open for debate in this country, and we have to allow for a discourse around the epidemic. And sometimes we'll be right and sometimes we'll be wrong, but that's important for us to be able to engage in a safe way in the country. And it's important to engage in a safe way in the country because we all have our country's best interest at heart, and we all want this epidemic to be managed in a way that optimizes outcome and increases social cohesion and trust, both in science and in the government.
I don't think I can add anything more to what Glenda has said, except to say that I think that that having a number of groupings commenting on the same information is actually very useful. As long as the material that is being produced is not clearly fake information that is being propagated, but actually deals seriously with the information that's available. Thank you.
Yeah, I don't think I have anything to add to this discussion because I don't know about this group in the UK.
Thank you. I just want to ask the organisers if any more questions have come in that I don't know about. I don't think so. Oh, we have one from Professor Maluleke.
Yeah, listening to all the presentations, especially the presentation of Professor Gray and Professor Crew, but also the others, I wonder whether, I mean, to take the suggestion of Professor Vail a little further, whether we should not be thinking about pandemic worthiness as a national development goal, if not an international development goal. I mean, we talk about the SDGs now. It seems to me that the whole world was caught napping in some ways. So the question of how can we be better ready surely cannot just be a national question, because no country can be ready on its own. If COVID-19 taught us anything, it is that there are interdependencies between countries, but also between human beings, and also between human beings and other life forms on Earth, and that we ought to plan for this a little better than we have done this time around. And perhaps no single nation can do it alone, but certainly every nation ought to include in all its plans, whether you call them economic plans or development plans, something to do with pandemics and public health issues. And I wondered if Professor Crew and Professor Gray and others would want to comment on that.
Thank you very much, Professor Maluleke. I think that there's obviously a need for a greater level of pandemic readiness, but I think that one of the issues that makes it difficult is the actual details of the way in which the pandemic is going to play itself out within the human population. And so I think that that's what we have been observing now, is that this pandemic, as Professor Gray has indicated, was significantly different from, let's say, SARS or MERS or some of the flu epidemics. And so although there was some readiness to deal with issues like that, what the what this current pandemic has indicated is that if you get something that really produces a significantly different effect, then you need to think how you're going to make your pandemic readiness effective. And I think that the real problem is that both the effects are unpredictable and the timing is unpredictable. And if the timing has long lags between them, then what happens is that you get readiness fatigue in the intervals between pandemics. And so I think those are some of the issues that need to be explored once this particular pandemic is over, and we look to how to deal with future pandemics. Thank you.
Yeah, so I agree with what Robin says, is that it's hard to predict what kind of epidemic we're going to have next, and everyone might behave differently. But I think what this epidemic has taught us at a global level is the lack of health system resilience. Okay, so whether you were in New York or whether you were in Cape Town or in East London, our health systems weren't ready and our health systems weren't resilient. And what we saw both in the first world and in low middle income countries is that the normal health system shut down to be able to accommodate the COVID-19 epidemic. And so what happened? Cancer, TB, HIV, diabetes, knee surgery, eye cataracts. Our countries are never going to recover. I've heard that we'll never ever be able to catch up on our knee operations or our cataract operations because of this epidemic. And so what we need to do at a global level is make sure that our health systems are resilient, so that we don't miss a beat when this happens again. So that we should be able to continue business as usual, and we should have that kind of health system that doesn't get affected by these epidemics. And so at a global level, we suffer for lack of resilience. And the second thing that I would suggest as well, from what we've seen, is that just the diagnostic and laboratory infrastructure to take scaling to take testing to scale was lacking. Besides maybe Germany and Sweden and some of the European countries, Switzerland, is that we lacked, even in the US, they lacked an ability to take diagnostics and to scale. And so we need to improve on our laboratory infrastructure to be able to adjust our penetration of tests and to make sure that happens. So I do think, and then I think thirdly, information. So I don't know if you've been watching the debate in the US about the CDC and Debbie Birx about hospital data coming available, and that there's a lag in hospital data. And in the same way in South Africa, although we have Sentinel sites that are hospitals, we don't have a real-time access to the data that's coming out of hospitals. So I think if we can learn anything from this epidemic, we need to improve our systems to collect data in hospitals. That was lacking. We need to improve our infrastructure in our laboratories. And thirdly, we need to have a health system that's much more resilient than we have at the moment.
Thank you. I think we're finished with the questions now. And I want to thank the speakers for very interesting presentations. I just would like to mention, when we were chatting before the webinar started, Professor Gray mentioned that they've got an article in today's Daily Maverick, which is very relevant to this morning's discussion. It's from the Scientists Collective, and it's called Anticipating a Second Wave and When and How South Africa Should Try to Prevent or Mitigate It. So that is something to look at for what's coming in the future. And I just now like to hand over to Professor Ogudi to say a few words to wrap up our webinar.
Thank you, Professor Nicholson, and I want to start with by thanking the audience that has been following our deliberations so far. And thank you very much for the questions that you brought up. If your questions have not been answered, we hope that we'll, still find time to, reflect on them. But I also want to thank today's presenters, Professor Rodner, Professor Glenda Gray, and Professor Crew, people who were extremely busy, but gave us an extremely, insightful and illuminating presentations. Now, at the beginning of these deliberations on the impact of COVID-19, Professor Howard Phillips drew our attention to 5 fundamental effects of pandemic in general, especially in ways in which they surface the structural underpinnings of our societies, whether these be repressed prejudicial attitudes, whether these be issues of power abuse, but he also added that there's a sense in which pandemics can also trigger novel developments within society if we care to pay attention, both in the health sector, but also in the area of research, which concerns us most as academics and as scholars. So that not everything is lost, that there's a possibility that, a pandemic such as this one, hopefully, will help us to reflect deeply, on some of these issues. For example, if you look back at the series of issues that have been raised, some of the things that come out very passionately have been very subjective, and I'm using subjective in the sense of, things that are very personal. And Prof. Crew touched on this issue. When, for example, do we balance? Do we bring the balance between freedom in a context of such a pandemic, and at the same time allow the citizenry to exercise their most fundamental rights? What Prof. Crew was talking about had a lot to do with things that affect us at a very personal level and have long and extended traumatic effects. Imagine if you lose a father and the father is buried, or a mother who is buried and you've not talked to them. In all societies, that will leave you with, long-lasting, psychological and traumatic effects. So what it means, therefore, is how, as Professor Vale was asking yesterday, how do we get a language that would allow us to frame the crisis that we are facing, to force us to re-examine things that we have tended to take for granted? And Professor Gray has touched on the fact that our capacity for resilience has been most profoundly exposed, and it doesn't matter whether we are in the first world or in the third world. It doesn't matter whether you are dealing with the poorest of the nations and, the richest of the nations. So there are a lot of questions, and I'm hoping that, the series of seminars that we've had have helped us to reflect very deeply on some of these issues. I just want to conclude that over the last 1 week, I've been reading Albert Camus' The Plague. Albert Camus' The Plague talks to a plague that actually took place in Algeria, in a small town. And the most interesting thing is that the protagonist there is a doctor. And this doctor becomes extremely restless precisely because of what I think Glenda Gray called how politics impacts on science. You can see evidence of people dying around you. You can see people affected, but you turn a blind eye to these because of the political implications of acknowledging that we have a problem that we need to deal with and deal with, decisively. And I think these are challenges that we're bound to face going forward. And hopefully, whether in terms of our, context as scholars, rethinking higher education landscape, as Professor Moja challenged us yesterday, rethinking the place of technology, in our educational system, because it now seems it is inescapable. How do we grapple with all these things? And I think I'm really hopeful that, the series of discussions and deliberations that we've had today have forced us to reflect and think of a whole range of things, that we have taken very much for granted. But perhaps finally, in bringing us back to face our fragilities as human beings and also to confront the problem of uncertainty. I remember one time Prof. Rodner giving a lecture at our center, and he said that in science, uncertainty is almost an impetus for getting or wanting to know better. And I think it's critical that we embrace, not just our fragilities, but the sense of uncertainty, as we go forward. Once again, I want to thank you all. I want to thank members of our team that have been involved, the technical team here that have been involved in this, helping us with this project. I want to thank our own resource persons, Kirsty, that has been involved in organizing and working with our marketing division. I want to thank all of them. And I also want to thank Professor Maluleke that has been, was central in reaching out to some of our speakers, and hopefully in future you will join the Center for the Advancement of Scholarship in carrying some of these debates forward. I don't think we have had the last word on the impact of COVID-19. And thank you all to the speakers that have been involved in these deliberations. Thank you.